All right, so we'll talk about the intubation procedure. The person that's going to do the intubation will orient themselves at the head of the bed. So you may need to unlock the bed and move it forward to give you space to get at the head of the bed. You can put these handles down if they're bothersome to you. So basically, in order to do that, you just pick up on them and fold them down. Now this is a stretcher or a gurney. A lot of times in the hospital, if it's a legitimate hospital bed, one of the first things that you'll need to do so that you're not trying to lift over anything is the headboard. If you'll take the headboard and pick it straight up, it'll come out and then you can set it off to the side. You'll want to maybe move the patient so you can grab the sheets and stuff under the patient and pull them to you so that you're able to get, and also you want to make sure that you put yourself in a position so that you're comfortable. You don't want to try to have to bend over too terribly far. These beds, they do raise up and they go down. So put the bed at a position that's comfortable for you, because once the paralytic or what have you goes in, you know, your ability to manage that airway is the most important job in the room. So be able to manage the airway effectively with bag valve mask ventilation, and then you want to make sure that you can get the endotracheal tube in. So in another video, I showed you how to set everything up. Now, I do not have the luxury of having a partner with me today to hand, so I will do the laryngoscopy and grab the tube and stuff myself and put it in. But in a real world environment, you should likely be able to have an assistant to help you with that. And you should know the equipment very well, because you know, you may not always have another respiratory therapist to help you out. So you may need to be able to talk about the procedure, what you need done, and talk someone through it that's never done that before, never set that up for you before, so that they can do that. I actually had to do that one night working in the hospital. I had a nurse go through, and fortunately, you know, had been well trained, knew where everything was at within the crash cart, the airway box. So I was able to talk her through what was needed while I was breathing for the patient, and then she was able to come over and hand me what I needed, and we got the patient re-intubated. It was in a post-anesthesia care environment. But nonetheless, you're going to make sure that your bag valve have suction ready to go. If the patient has a pillow up under them, you're likely going to want to pull that pillow out. That way you can align do your head tilt, chin lift, assuming there's no cervical spine injury or anything to that effect, and get their airway lined up so that you can get in there and be more comfortable with doing the intubation, and align the airway axes so the air is moving in and out nicely through the lungs. And that's also going to improve your chances of being able to visualize the cords. So make sure that your bag valve mask device, you know, some of these have the popple tubing on it. You want to make sure that popple tubing is pulled all the way out, because that's going to serve as your reservoir. Some of those have a bag that's going to be your reservoir of 100% oxygen. And make sure that you're hooked up to an oxygen flow meter, and I'm not turning the flow meters on because I don't want it to drown out my voice. But make sure that it's turned all the way up. This flow meter is calibrated to 15 liters per minute, but it will put out greater flows than 15 liters per minute. So if I'm in a code scenario, code situation, I want to provide as much oxygen to a patient as I can, I'm turning that flow meter wide open as much as it'll go. So you've got your mask. You want to make sure that you can generate a nice seal with it. So you want to, you know, some individuals will start at the lip and close down at the bridge of the nose. Some individuals start at the bridge of the nose and close down over the mouth. You'll utilize a C and an E technique to maintain your grip. So you'll make sure that you can get you a nice good seal, get appropriate chest rise as you breathe in. You don't want to breathe too fastly for those individuals. If a paralytic hasn't taken effect yet, one thing you can do is just kind of hold it there. And one thing I'll tend to do is hold a little bit of pressure on the bag, and when the individual takes a spontaneous breath, the bag will collapse anyway. So that allows me to facilitate them. And then once I know the paralytics take an effect, they're not going to be breathing spontaneously anymore, so then it's on me. So you want to make sure that you're delivering a breath every 5 to 6 seconds, and deliver that breath over the course of about a second. You'll hyperoxygenate for up to 2 minutes. Make sure that you're, again, getting good chest rise as the patient's breathing. And once you're ready to roll, you can take this away. This is where I would, so we won't start the 30-second clock yet, but at this point, if I'm the individual helping, I'm going to assume that I'm going to hope that that individual gets the intubation. So I'm going to take the mask off and have my end tidal ready to roll. That way, I can just connect this directly here once the individual's performed the intubation. So I can set that aside, and hopefully I don't knock it in the floor in the middle of doing the intubation. You've got suction ready, so the 30-second clock is going to begin once this blade, well, technically it should begin once you stop ventilating for the patient, because they're no longer breathing. So you're going to go into the right, and you're going to sweep the tongue left, and you're going to make sure that you move in a forward direction so that you're not rocking back on the teeth, because you could break the patient's teeth. So you want to make sure that you, I'm utilizing a Macintosh blade, so I've slipped this into the vallecula, and I'm lifting forward. I've got the vocal cords in my view. In a real world scenario, I would not take my eyes off of that. Wouldn't take my eyes off of that because someone would hand me the tube, but because I've got to grab it myself, I'm going to go ahead and I'm going to insert from the right. That way I can watch that tube all the way as it passes through the vocal cords. You're going to insert the tube just until the tube passes through the vocal cord. Pull this out all the while hanging on to your endotracheal tube. I like to utilize the bed and close that down so that the blade doesn't get hot. Pull your stylet out, making sure that you're hanging on to the tube because it's in the right spot. You don't want to lose it. And I'm going to go ahead and inflate my cuff. And now I'm ready to take this and attach it. And give a couple of breaths and watch for color change. Now obviously this is not a spontaneous or a live subject, it's a mannequin, so there's not going to be any color change with this particular one. But I am going to assess for color change. You can watch for condensation to build up in the tracheal tube, but ultimately take your stethoscope and you want to listen bilaterally to make sure that you've got equal bilateral breath sounds. You can also listen over the stomach to make sure that you're not in the esophagus, and every time you're squeezing that, blowing air into the esophagus, because then the patient's likely going to throw up. Now this was a mannequin prior to the intubation, so I did not have to suction him, but if I did need to, my yonker was ready to go so that I could have suctioned the mouth out if I needed to clear that to visualize the vocal cords. So what I always like to do is I'll call out that I have a 7-0 endotracheal tube. I've got equal bilateral breath sounds, no sounds heard over the epigastric area, and I am 24 at the lip. 24 at the lip with equal bilateral breath sounds. And now I'm gonna, while someone would, I can either breathe or I can either breathe for the patient while the individual, but I'm at the head of the bed, so it's gonna be easier for me to secure the tube. So I may ask someone to breathe for me while I secure the tube. So you've already pre-cut your tape and it's within reach. So you can either tape, our tape's not gonna stick to these mannequins very well. So I'll utilize a commercial tube holder. And notice, I've not let go of this endotracheal tube. And you still want to make sure that someone's breathing for the patient as well. You're monitoring your vital signs, making sure your heart rate's good, SpO2 is good. If you were to insert this endotracheal tube too deeply, based upon the anatomy of the airway, you're likely going to go into the right main stem bronchus. So you want to make sure that, you know, if you happen to see unilateral chest rise and there's more chest rise on the right and decreased diminished breath sounds, what have you, on the left, and if your tube's at say 20, 26, 27 at the lip, it's definitely a good indication to back that on out. But before you move that tube, make sure that you deflate the cuff, pull it back, and then reinflate the cuff. You don't want to be dragging an inflated cuff through the trachea. So do that. And then just at this point, make sure that you hang on to the tube and you go about and secure it with the tube holder. So I'm going to disconnect here, and for the purposes of my video, we will pretend that someone is continuing to manually ventilate for me and that we're attached there. But this happens to be a commercial tube holder. You'll want to make sure that you place it on the page. It's got an adhesive pad that'll stick to the cheeks. So you can stick that to the cheeks, and then it's also got an adhesive strip that'll wrap around the endotracheal tube. On the bottom of this, there's a couple of sharp points that'll kind of dig. They won't go through the endotracheal tube, but they'll stick into the rubber. That way you can secure that. So with the adhesive pads on the page head, then I can take and run this behind the head. Run this behind the head. And secure the other side. When you're securing, you want to make sure that you don't pull it too tight, but you want to make sure that you've got it tight enough so that your tube is secure. As a general rule of thumb, whether it be an endotracheal tube tie, tracheostomy tube ties, or what have you, as a general rule of thumb, you want to make sure that you can get a minimum of 2 finger widths up under there. If you can get 2 finger widths up under there, it's likely pretty good. You're also going to have a chest x-ray ordered so that you can verify tube placement. On that chest x-ray, you're going to make sure that the tip of your endotracheal tube is 3 to 5 centimeters above the level of the carina. That's what we utilize for the purposes of MBRC and your MBRC board exams. In the real world, you may hear a lot of people say 2 to 4 centimeters, but just as long as you've got at least 2 centimeters, 2 to 3 centimeters above that carina, you should be able to allow ventilation to both the right and the left lung. So that is your intubation procedure. And I said, just make sure that you're fluid with it. You're going to have a partner to work with, so you won't have to spend as much time looking for anything like I did. And then once you have got them intubated, then you can disconnect your manual bag valve mask and then attach to your ventilator after your ventilator's been set up and ready to roll. So we'll do a video on how to extubate here shortly.